Hello, everyone, and welcome to the Accelerator Program Core webinar in our Boots on the Ground webinar series. Today's session is on strategies to prevent overdose deaths. I am Amy Max, Program Manager for the California Opioid Safety Network here at the Center for Health Leadership and Practice, which is a program of the Public Health Institute. I'm very pleased to be welcoming you today. Before we begin, I want to review some webinar housekeeping information. On your screen now is the 866 number for WebEx assistance. Please reach out to them if you have any technical difficulties. Also, feel free to use the question and answer panel as shown on the screen for any questions that you might have outside of the live discussion segment. Please type your questions into the panel and direct them to all panelists. Please also remember to click send, and we will have more details in a few moments about the format of today's webinar discussion. On the slide here are the desired outcomes for today's webinar. So at the end, you will understand the trends in overdose deaths in California, be able to describe potential strategies that opioid safety coalitions can implement to reduce opioid overdose deaths. We'll provide practical suggestions for implementing strategies based on the experience of other coalitions, and provide a range of available tools and resources to help you implement those strategies. Here's the agenda for today's webinar. We'll be going through the trends, harm reduction opportunities, existing strategies, have some guest speakers to provide lessons from the field, tools and resources, and then an opportunity for some live discussion and Q&A. I'd now like to introduce Karya Lustig, who's our Deputy Director for the Center for Health Leadership and Practice, who provides some more detail about today's webinar.
Great, thank you, Amy. Welcome, everybody. So these webinars that we offer as a part of the California Opioid Safety Network are also a part of our Accelerator program. They offer resources, support, and a network to build a movement here in the state that's helping to reduce opioid deaths. Today's webinar specifically is a part of the Boots on the Ground webinar series. It's associated with our model, which is on the screen now. The right-hand circle is about opioid strategy implementation. And the other topical areas are covered as a part of other core webinars that are a part of this first phase of the program. This webinar today is the last of a three-part series covering the main strategy areas of opioid strategy implementation. So this will conclude the first phase of the program offerings in this area. As with all core webinars, we're focused on providing a very broad overview of the topical area in hopes that we can deepen knowledge in areas that you might have some understanding of, or open opportunity or knowledge in new areas that you might be interested in exploring. We are covering specific areas around naloxone, needle exchange, safe injection sites, and others, and hopes to have a great discussion following our core content that we're going to be offering today. In the next phase of the program, we'll do deep dives into a variety of topics through some informal subject matter expert facilitated dialogue that's focused on leveraging the network and supporting cross-coalition learning. So please remember to complete the survey at the close of the webinar so that we can learn more about topics that would be most supportive to you for your local work. And this could be deep dives into areas that you hear about today that you're hoping to learn more about, or to talk about challenges with other coalitions with. So to kick us off today, we wanted to run a poll so that we could get more familiar with some specific areas, and then use that to guide our webinar content. And following the poll, I'll also introduce our speaker for today. So on your screen right now, there should be a poll that's popping up. The question is, in your community, which of the following settings or sectors are highest priority for carrying and or furnishing naloxone within the next year? You have a number of options: police, jail, schools, clinicians, pharmacies, syringe exchange, homeless providers, or other. If you could please complete this and remember to hit send after you make your selections, then we can see those, and we'll have the poll results pop up in a moment, and our speaker will be able to review them as we kick off our content. So I'd now like to introduce Dr. Matt Willis. He's our clinical lead for the California Opioid Safety Network. He's also the Marin County Public Health Officer, a primary care physician, and an epidemiologist. He's co-founder of RxSafeMarin Opioid Safety Coalition and is a member of several state opioid task forces. Welcome, Matt.
Thank you, Karya. Hi, everyone. So today Oops, make sure, there we go. So our vision that we share across the network is moving towards zero opioid overdoses. And to get there, we know that we need to simultaneously be addressing the problem of opioid oversupply and availability, high opioid demand, and to take new steps to prevent overdoses in real time. These have been the themes of this first phase of support in our Boots on the Ground webinars. Of course, there are going to be multiple strategies in each of these areas, and we'll be focusing on practical strategies that are emerging as successful from within the coalitions. So the subject matter experts for much of this is actually from you all, from people who are out in the field doing the work and demonstrating success in one area or another, and we have two excellent examples of success that we'll be hearing from on the call today. I'm going to start with some trends in opioid overdose deaths for the state of California. I want to sort of offer the framing of the call today is preventing overdose deaths. One of the other ways this is framed as being harm reduction. The best way to understand the strategies that we're talking about today here is to think that given that opioids are misused and addictive, how can we prevent the harm we know is associated with opioid use? So it's sort of a pragmatic and humanistic approach that says, even as we work to limit the supply of opioids through safe prescribing and drug take-back, reduce the demand through access to treatment, which have been the themes of the previous calls, we know that people will be using opioids in ways that could harm them, and we want to keep them alive and as healthy as they can be as they move towards recovery. So that's the harm reduction framing for this particular call. Again, reminding us that we have available to us the California Opioid Dashboard for any of us looking to be data-driven in our work, and you have access to that data for your county and zip codes within your county. And I'm going to offer some of the data from the dashboard. And I'm trying to advance these slides. There we go. So this was a study that was done last year looking at 10 different scenarios and projecting out the number of overdose deaths we might see over time based on the strategies that we implement collectively across the nation. The bad news is that this highest line where we see the highest number of overdose deaths over a 10-year period is in fact our current trajectory. And what this invites us to do is to realize that, you know, if we are actually successful in the strategies we're moving forward in safe prescribing, in reducing demand through increasing access to medication-assisted treatment and harm reduction, we might realize that more optimistic lowest line, the blue line, that shows that we would be seeing a decrease in the number of overdose deaths, but only if we're able to successfully implement those strategies simultaneously and in parallel. Unfortunately, this is the latest data we have for the trends. What this shows across the nation is that we're seeing an acceleration of the opioid epidemic, and the primary contributor to that acceleration is seen here on the orange line that shows that synthetic opioids like fentanyl have emerged from 2015 onward as the major contributor, more than prescription opioids. If we look at the state of California, going back to our dashboard, we see a remarkable increase in the number of fentanyl-related overdose deaths. On the left axis, you have the number of prescription overdose deaths, and on the right is fentanyl. So we see it's still lower overall in terms of fentanyl, but the rate of increase is much higher. There was just last week, the CDPH came out with the latest data, and the Times picked up a story that basically showed, and this is from that article in the LA Times, that there was a tripling in the number of fentanyl deaths in the state of California from 2016 to 2017. So as dismal as that 2016 data I just showed is, 2017 is looking a lot worse in terms of our relationship with fentanyl. So that brings us to the phases of the epidemic, which is prescription opioids in phase 1, 96 to 2012. Phase 2, where from about 2012 and now ongoing, we're seeing more heroin use. And then in 2016, a rapid acceleration of the use in fentanyl. So the question, I think, for us as leaders in this space is how do we adapt our strategies to meet the increasing scope and complexity of this epidemic? One of the features that we need to acknowledge is as fentanyl becomes more and more prevalent, that there's different dynamics within the fentanyl epidemic, and it tends to be, as this graph shows, younger people. So what this graphic shows is the proportion of opioids that contribute to death for different age groups. And what it shows is that for age 15 to 24 and age 25 to 34, fentanyl and heroin are the primary contributors to opioid overdose deaths. And in older age cohorts, you see prescription opioids are actually the primary contributors. So some of the work that we've been doing in safe prescribing and increasing access to MAT may or may not actually address all the determinants of use and overdose risk in those youngest age cohorts, because those individuals may not have a history within their own life of antecedent, opioid prescriptions, and may not actually have some of the classic features of addiction, where they may have been identified as someone who is having regular use and should be offered access to MAT. We're seeing much more use of fentanyl or lacing of fentanyl with other drugs of abuse like methamphetamine and Xanax and other benzodiazepines, as well as cocaine. And so the dynamics there are really, I think, informing the strategies that we'll be talking about today in terms of harm reduction, I think are even more important when we recognize that safe prescribing and even access to treatment may not be relevant to some of these youngest phase people who are dying from fentanyl overdoses. This is from JAMA that basically shows the same thing of the different, 2001 to 2016, showing the proportion of total overdose deaths attributable to different agents, or this basically shows the age distribution of overdose deaths, and shows that that youngest age cohort is being more heavily hit than other age cohorts, and it's partly because of the increasing contribution of fentanyl. Next slide. This is from the JAMA study that just came out in 2018. 335,000 opioid-related deaths in the United States from 2001 to 2016. And I share these partly for your knowledge, but also for your library as coalition leaders to use in your own communities when communicating about this. In 2016, there was 42,000 opioid deaths, which was an increase of 345% from 2001. And what's important about that is that because of that age distribution being primarily younger, the years of life lost is over 1,600,000 years of life lost. So this is an epidemic that's affecting young people primarily, unlike some of the other problems of addiction and substance use that we see with alcohol and tobacco that tend to affect people later in life. Synthetic opioids also, for the first time, eclipsed prescription opioids as the contributors to death. So the author of this study said that we've been focused on the threat of prescription opioid overdose deaths, but that we need to remain vigilant about the ever-shifting nature of this crisis. This is a study or a graphic that came out of Bloomberg that I thought was really helpful in terms of understanding the difficulty in controlling the supply side with regards to fentanyl. And basically what it shows is that there's more than 100 companies in China who are manufacturing and distributing and mailing fentanyl in packages to the United States. That it's clear in recent conversations. I heard a story on NPR about this, that the U.S. Postal Service and others just have no ability to manage and monitor every package coming, and there are many of these are less than 1 pound, which is when it comes to fentanyl can be actually enough for an entire community. So again, with the increasing available fentanyl and heroin, overdose rates are accelerating, and we need to make opioid use less harmful, which is the theme of our conversation today. So harm reduction is both kind of a proper noun and a concept. When we talk about harm reduction, in opioids, we're often returning to naloxone strategies, needle exchange programs, and safe injection sites. But conceptually, harm reduction is, a constellation of policies, programs, and practices that aim to reduce the harms associated with the use of opioids rather than prevention of drug use itself. We accept that drug use is part of our world and work to minimize the harmful effects rather than ignore or condemn them. It acknowledges that some ways of using drugs are safer than others, and we establish quality of individual and community life and well-being, not necessarily the cessation of all drug use, as a criteria for successful intervention and policies. So this is one of the reasons why harm reduction strategies tend to be somewhat politically fraught in areas where people have different ideas and stigma related to drug use. Next. So I'm looking at the results of the poll as I wait for the next slide to come up. Looks like for the majority of respondents, the police was the highest priority, or the most popular response was police, although everyone had at least only one that wasn't represented was homeless providers, some with syringe exchange, two with pharmacies, clinicians, schools, and jail. Great. So we'll get to some of the strategic support for all those. So I'm going to start with strategies for naloxone distribution. As you probably well know, naloxone reverses opioid overdoses by having very high affinity for opioid receptors. When opioids contribute to fatal overdose death, it's because they are occupying receptors in the brain that not only control some of the known effects like pain and euphoria, but also respiration rate and other autonomic functions like heart rate. So when people are overdosing on opioids, essentially respirations are suppressed to the point where they may stop breathing, at which point you have about 3 minutes before the heart may stop and the brain will stop functioning. Naloxone can actually very aggressively replace the opioid receptors, replace the opioid on those receptors and restore normal physiology and normal breathing. So it knocks the opioid receptor off the opioid off the receptor. It only works on opioid receptors, so if there's no opioid on board, there's no effect. And there's no harmful effect if there's no opioids on board, which is an important point to reinforce in our conversations with partners. It temporarily reverses the opioid effects, restoring respiratory drive, works in 1 to 3 minutes, and lasts for 30 to 90 minutes. It's neither a drug of abuse nor can it cause overdose. We've had cases in Marin where someone had naloxone on board and was actually accused by the police, who didn't know what this drug was, of actually carrying an illicit substance. So it's important people know that it is not a drug of abuse. The only known contraindications are sensitivity, which is very rare. Obviously, if someone is opioid addicted and has changed their physiology, using naloxone can actually cause withdrawal symptoms, nausea, vomiting, diarrhea, chills, and other known symptoms of withdrawal. This is evidence of impact coming out of San Francisco. This was Philip Coffin, who's done a lot of work in the city on increasing access to naloxone. And basically, this was a study that looked at almost 2,000 individuals who were receiving prescriptions for chronic pain and offered them naloxone and in a risk stratified way. So people who are on higher doses were getting offered naloxone at greater amounts than people who are on lower doses by primary care physicians and 6 FQHCs. And basically what it showed is, following those people prospectively over time, that after having been given naloxone, there's a significant reduction in emergency department visits related to opioid overdoses. And that was thought to be related to 2 factors. One was that they were not having the events, that they were not needing to go to the emergency room as much because they were having events that they reversed. That is not endorsed as a practice, and of course we want to make sure that anyone who's having an overdose event, 911 is called and they go to the emergency department. But also importantly, the people who were given naloxone and the training that went along with that from the clinician were actually more aware and educated about the risks of the behavior of taking too many opioids, and actually changed their own opioid consumption practices and had fewer overdoses and explained, just fewer events of overdose. Bob Coffin also did another study of cost effectiveness and basically demonstrated that there was about $421 per quality-adjusted years of life gained, which, if you're looking at the data around qualities, is actually one of the most effective forms of, of intervention in terms of the cost per year of life gained, and that 164 naloxone scripts prevented 1 death. And if you take into account the fact that people are actually disincentivized from over-consuming opioids when they have naloxone, that actually goes down to 1 in 36 opioid prescriptions in some of the models for saving 1 life. So there's there's a few other studies that show cost effectiveness. Philip Coffin has actually published 3 of them, and they're available for anyone who's interested. We'll make these available to you if you're trying to make the pitch in your community. Another important potential barrier to distributing naloxone at the local level is that some people are afraid of the liability that may go along with carrying naloxone if it's not something that's been prescribed to them. In some ways, our legislators were ahead of public health, and back in January 1, 2014, legislators actually made it much more easy to obtain naloxone for family and friends who are people at risk of overdose. And this is Assembly Bill 635, the Overdose Treatment and Liability Act, which basically allows bystanders to administer naloxone in an emergency, protected from civil or criminal liability for adverse outcomes or practicing medicine without a license. I think we're mostly over that concern, but if anyone raises that, there are laws that you can point to. And then this is another important piece of legislation, which is Assembly Bill 1535, which in September of 2014 authorized pharmacists to furnish naloxone without a clinician prescription in accordance with protocols approved by the Board of Pharmacy. On January 27, 2016, the Board of Pharmacy did announce those regulations and is now legal for pharmacists throughout the state to furnish naloxone without a prescription. However, we know that a minority of pharmacies are actually taking advantage of that law, and that's one important point of advocacy for us as clinicians. So as we work towards strategies to increase the availability of naloxone, here's an important organizing question for us. Is it possible to design a system where a witnessed opioid overdose is no more than 2 minutes from naloxone rescue? And what would that system look like? And the way I think of this is to just, imagine from a physiologic standpoint that we have, if someone has overdosed and they're no longer breathing, that there's a window there where you may intervene and save a life if the naloxone is present and at hand and the bystanders are aware and it's used. And if it's used at that point, that person can be revived and maybe have decades more of life, especially now that we see that there's an increasing younger and younger age of overdose deaths. So that's just an organizing question around what that system would look like. The CDC offered some suggestions about what that system might look like in a recent infographic that they released called, where they basically are helping coach public health organizations and other sectors around the need for a coalition-style strategy where we're having multiple sectors come together to address clusters in opioid overdoses at the local level. So you as coalition leaders are in a really good position to actually implement what the CDC is formally recommending as a national approach to this issue. I'm sorry, it's taking a little while for some of the slides to advance. And in most of these, in this graphic, naloxone distribution is actually part of the strategy for that particular sector. So when it talks about local health departments or community members or first responders, the little bullets there that are too hard to see include, naloxone as one of the strategies. I'm sorry, I can't. There we go. So this is the graphic that we looked at last time. We were talking about medication-assisted treatment and saying, how do we increase the opportunities across the system to have MAT more widely available through the network we know we've already assembled through the coalition. And the same holds true for naloxone. We want to think about all of those partners as being potential partners in naloxone distribution. Here's an important analogy that I thought was apt for this, and something that we've talked about in Marin, which is, you know, about 15 years ago, there was a huge movement to get automatic electronic defibrillators, AEDs, widely distributed throughout communities because people who are having heart attacks and had cardiac arrhythmias, there was a really strong correlation between, you know, the ability to shock someone back to a normal rhythm, you know, within a time, you know, within a few minutes, and overall survival. And so there was a lot of work to think about how do we get AEDs effectively distributed throughout the community. And this is just an example of one effort in Toronto where they mapped out cardiac arrest locations and then mapped out the locations where AEDs should be placed throughout the city in order to address that. And I'm encouraging us to think that way about our naloxone distribution across our community. As coalitions, these are examples of some of the partners we have available to us and which you responded to in your first question. And it looks like everyone, you know, has some interest in partnering with at least one of these sectors over the next year to increase naloxone availability. So these are some of the steps that coalitions can engage in increasing the naloxone at your community level. Some of this has already been addressed in some of the other calls. Just referring to the first step, which is creating a call to action. You've heard from IE Communications around how to create an effective call to action. This is an important piece in any of the work we do, which is essentially when we're trying to invite partners into this, making the pitch. So first is creating the call to action, educating regarding the local need, using local data. Obviously, sector-specific communications, so you would speak differently to law enforcement than you would to schools around this, and then also increasing overall public awareness. Coalitions can train partners, so when we're asking partners in schools or in jail or in pharmacies to actually do more around naloxone, often training is an important element, and we can offer that training as coalitions. We can provide protocols, and there's an increasing number of canned protocols that are available that you can use, sector-specific, and some of those will be made available. Obviously, providing the product itself, because we know this is a life-saving remedy, and it's about $75 a dose. I know if we, at least through the Adapt Pharma nasal spray, we want to make sure that the lack of product itself is not a barrier. And so the state and other funding agencies have actually made it more available for us to find special pricing or free access to naloxone for distribution at the local level. The intranasal naloxone through Adapt Pharma is generally emerging as a preferred agent, partly because of cost and ease of use, but, and I'm not going to get into all the different forms of naloxone on this call, but you know, that's information that's available, and there are at least 4 different modes of administration of naloxone. And then we want to, if possible, monitor the use of naloxone after it's been distributed, tracking the distribution, who we've distributed to, how many kits, and how many have been refilled. One opportunity there for actually tracking naloxone use at the local levels through emergency medical services data that you may have access to. That's something that the state has been helping support some counties in actually reaching out to their 911 system to get overdose death data, which allows us to see temporal relationships and geographic relationships in overdose events. And then importantly, celebrating the rescue. So when we have partnerships in place, we want to make sure that and the rescues are happening. We've seen this across the state where almost as soon as a partner engages in carrying naloxone, there's some early successes in terms of its successful use to reverse overdoses, and that's happened with librarians, that's happened with in our schools, that happened with our first responders, and it's a really great opportunity to sort of celebrate and strengthen those connections. This is an example of some of the information we used in Marin to create the call to action for our clinicians, just using the local data to show that over half of all drug overdose deaths in Marin occurred at home, to make the case that we should make sure that friends and family have access to naloxone. there are trainings that are available. We'll make trainings available to you online on the online resource library. Emergency medical services for first responders, the state requires that emergency medical services at the local level approve the training that's offered to first responders, and there are EMS-approved naloxone trainings available. This is the one that we used in Marin County, which we actually stole from Sierra Sacramento EMS agency, and so there's a lot of sharing of these EMS-approved naloxone trainings that are important for the first responders, but work for every other partner as well. Providing protocols. This is something we recently did in Marin, working with our schools, and making the pitch to school nurses and school administrators. It's a lot easier when you have a protocol in place that you can share and say, this is what this would look like, and offer them a chance to edit and augment the protocol so that you find something that you can agree to. And there are editable versions of these protocols also in the resource bank. Monitoring use, this is an example of what we're doing in Marin around actually seeing the number of overdose events that are responded to by our EMS agency, and we can actually see the number that where the reversal occurred, and it really makes the case very effectively. We need to make it more widely available when we're seeing that 154 incidents in a small county like Marin. And then these are two examples of celebrating reversals in media. This was a story that aired right after we had trained our first responders in Marin, that a Novato officer actually saved an overdosing man's life. And this became one of the, at the end of the year, one of the top 10 stories in Marin for the local newspaper was this particular story. And then on the lower right, you have a picture of a librarian, I think in Humboldt County, who found someone in the stalls who had overdosed and used naloxone to save a life. This is an example of California Department of Public Health has made naloxone more widely available to public health departments. And these are some of the sectors that, as of March 2018, that had actually been distributed, had naloxone distributed to them through CDPH. Syringe exchange programs, substance abuse disorder treatment services, homeless programs, law enforcement agencies, and jails were all receiving naloxone through public health departments at the local level that had come from CDPH. So next, we're going to address needle exchange briefly. We're going to hear mostly about needle exchange from a program that has effectively implemented this, but just to offer some context for that, when we think about harm reduction and needle exchange, I think the simplest way to imagine this is actually through a really stark example that happened in Indiana. You're probably aware of this. In Scott County, Indiana, a population of 24,000 people, so a small county. At 185 new cases of HIV over a 6-month period, young people median age 33, mostly male and white. 92% of them were co-infected with hepatitis C. So there was a hepatitis C HIV outbreak of 185 cases in 6 months, which is more than you'd expect even in a city like New York City or Los Angeles. Most had been injecting Opana, which is a prescription opioid, and shared injection equipment. So this is a infectious disease outbreak that was actually had its roots in opioid injection. So how do we prevent these sorts of things from happening? We know that from a cost, even just from a cost standpoint, the cost of managing someone with hepatitis C and HIV, when on the other end of that would be the cost of a clean needle, there's a clear argument for the cost benefit of syringe programs. CDC did a study looking at vulnerable communities and jurisdictions that experience at risk for outbreaks, and California has counties that are at risk for outbreaks, partly because 7% of HIV infections in California were among people who inject drugs. So the opioid epidemic, in some ways, as it accelerates, it runs the risk of actually increasing our rates of HIV and hepatitis C, which had been, up to this point, reducing partly through the access of antiretrovirals and others. These are other infectious diseases associated with injection. Just from a harm reduction standpoint, if we're trying to support safe needle exchange, these are some of the other harms, and especially in the infectious disease space, that we would be preventing. And finally, safe injection sites. This is a more extreme version of harm reduction. This sort of takes the benefits of safe needle exchange and adds bricks and mortar to it, and sort of standardizes it as almost like a clinical intervention, where there are locations where people can come and actually under monitored and safe conditions engage in what is otherwise and what is illegal drug use, in order to make sure that it happens safely, to reduce overdoses, and make sure there's someone there if there is an overdose event who can reverse it immediately, and make sure that the practices are safe. There's approximately 100 sites in 65 cities globally, and there's legislation still pending at the state to actually pilot safe injection sites in some California cities. San Francisco is probably the first site that would move forward with this, and they did a report in 2017 that estimated there'd be a $3.5 million per year saved if one safe injection program were opened. In 1 year, one site would prevent 415 hospital stays and 19 hepatitis C cases, and 110 drug users would enter into treatment because they would have an opportunity to actually be identified and linked to care through that setting. So that's the quick overview of some of the primary strategies that we'll be diving into a little bit more strongly. This is Senator Scott Wiener, who is one of the real champions, proponents of safe injection sites. So we need to do everything in our power to keep people healthy, get them off the streets, and a safe place indoors instead of on people's doorsteps or in public parks, and we can intervene quickly if there's an overdose. So now I'm going to hand it over to my friend Nicole Quick, who is the Public Health Officer in Yuba County. Nicole is a board-certified doctor in public health and general preventive medicine, and is a diplomat on the American Board of Addiction Medicine. Nicole has been working with the Opioid Safety Coalition in Yuba, and brings a lot of expertise, both as a public health officer and someone with specific knowledge and expertise in addiction, and has been a real advocate for us across the state. You can take it, Nicole.
All right, thank you, Matt, and thank you for that presentation. There's a lot of very useful information in there. I'm going to start out by just briefly kind of describing Yuba County, because most people don't know where Yuba County is, and I have to apologize. The arrow that I put on this map here of Yuba County is actually on Sutter County. So if you just picture this arrow and move it over like half a centimeter on your screen, Yuba County is that darker orange one situated there. And as you can see, Yuba County is a relatively small county. Population is under 100,000. We are, a non-urban area, very conservative and underserved as far as medical needs, including access to treatment for any substance use disorders as well as opiate use disorder. And as you can see from this map right here, our rate is amongst one of the highest in the state as far as opioid overdoses. So going to the next slide here, we rank 5th, so our rate is just above 13. Now, if you look at our total count of opioid overdoses, we're only at 9, which is relatively small compared to statewide, but once again, we have a small population. So, I've been in Yuba County for the last 3 years, and coming in here, I kind of knew ahead of time that Yuba County had an issue with substance use in general, opiate use disorder specifically, and that became even more apparent when we did our, well, actually, I wanted to briefly touch on this because Matt brought up the fentanyl trend in the state. Yuba County right now ranks 7th in the state as far as fentanyl overdoses, and we're expecting to see even more rise in there. So this makes our focus on getting naloxone out there even more important because, as he mentioned, people overdose from fentanyl earlier in their use of opiates than we see with prescriptions and or heroin. So it's kind of a dire circumstance in general. Get to the next slide here. So just to give you a little background about what happened in Yuba County, as I mentioned, I've been here for 3 years. When I first started, I kind of did some research, kind of see what the nature of the landscape was in Yuba County as far as treatment for opiate use disorders, knowing even at that point that we had a problem there. And what we kind of found is our ability to treat people with opiate use disorders. Our behavioral health is shared between the county next to us, which is Sutter County, and there wasn't anybody in behavioral health that was waivered to prescribe buprenorphine or to treat people with medication-assisted treatment. So we kind of looked elsewhere to see what is our capacity to treat people, how are we going to address this, and we had one FQHC that has providers there willing to treat people for opiate use disorder. So back in 2016, we set up meetings with them just to find out what's your capacity to treat, what are you doing with naloxone, and at that point, that FQHC was co-prescribing naloxone for all of their patients coming in to get treated for opiate use disorder. So we knew we were getting some naloxone out into the community. In 2016, we also did Yuba County's first community health assessment, and this was not surprising to us, but what rose to the top of the list was substance use disorders, specifically opiate use disorders. So we already had sort of this informal opiate group that was meeting, talking about naloxone and medication-assisted treatment, but we really used our community health assessment and then our community health improvement plan, which we finalized early 2017, as a way to formalize this group. So we put distributing naloxone as well as increasing access to treatment as one of our top priorities, with goals of addressing opiate use disorder. Now in 2018, our medical society is a tri-county, so it's Yuba Sutter Colusa Medical Society, and there's a healthcare council that meets within the Yuba Sutter area, and the two had kind of, independent of public health, gotten together and created a Yuba Sutter Healthcare Opioid Coalition, sort of apart from us really knowing what was going on. When we found out about them, we were more than happy to combine the two work groups together, because we had law enforcement and public health sitting down at the table, as well as many of our medical providers on our community health improvement plan, but really that was no reason to have two groups working on the same thing. So we combined those two groups together and sort of focused the effort on how are we going to address this and how are we going to get naloxone out, as well as all of the other pieces of the puzzle that I will talk about here in just a moment. So as far as naloxone, and what we've done to get that out into our community. Now, the reason I titled this slide Public Health Naloxone is I'm really referring to where the funding came from. So this public health, we used some public health funds as well as some of the state-distributed naloxone to initially, what our first focus was first responders, and I'll talk a little bit about why. And I thought it was interesting on the poll that we did that a lot of people, it looks like almost the majority said that police was going to be their priority area. And it was our priority area at first in Yuba County as well. And for me, the decision point was what could we do quickly, and we needed buy-in from other community members. So first responders, we looked at police, sheriff, and fire, and we have now distributed naloxone to all except for one area in all of Yuba County. I think there's one police that we still need to do, although we have them on and we just haven't done their training yet. So we distributed to the police, the sheriff, and fire. So up in some of our foothill communities in Yuba County, the first responders are often our volunteer fire departments. They're just logistically closer to all of these responses, and some of them have actually carried naloxone for quite a while. But there were some holes in that. Now, Matt had also mentioned that if you're going to be training EMS, that there's EMS-approved training. So what we did in Yuba County is we developed through public health our own short training, although the one that we do for first responders is a little bit longer than the one we do for public distribution, but we developed that, and then we had our EMS approve it. So SSV is actually our EMS, and we just sent them our training. They said, yes, that's great, go ahead and use it. And honestly, it's very similar to the ones that they have as well. We just the people developing wanted to do some slight differences to affect some, local flavor. But we went ahead and did that. We developed training, tracking forms, as well as kits. So our naloxone kits that we give out have the 2 doses of naloxone. They've got gloves, they've got a little card reminding people what to do, and we also have face shields so people can provide rescue breathing. Now, some of our first responders have elected to just get the naloxone from us. If they're adding it to a kit on one of their fire trucks and or some of the law enforcement wanted to put it into the first aid kit that their people carry, we went ahead and just gave them the doses. But for a lot of people, we give them this whole little kit that's in a nice bag and it just keeps everything together. And for some people, what they're doing is carrying it back and forth so that it goes out with the patrol cars. At other jurisdictions, we've gone ahead and given it to every one of their deputies so that people can take it home, and that way they also have it when they're off duty. And I also wanted to mention, when we, and this is sort of just my personal preference when we thought about our naloxone program, our goal is really to get this into the hand of the public. So what I see law enforcement is a step in that direction. However, I see that more as sort of expanding their scope of practice versus getting it out into the community. But I think it has some real benefits because, once again, you can do that relatively quickly. You can also get sort of public perception maybe a little bit shifted for some of the law enforcement, as well as get the word out there. So we historically, and I don't think this is unique to Yuba County, have had examples where patients who are, let's say, going to their doctor to get buprenorphine and they also have been co-prescribed naloxone, they've been pulled over, law enforcement searches them for whatever reason and they find the naloxone and it's either taken away from them or, what, like Matt had mentioned, accused of carrying an illegal substance. So I think by getting law enforcement in early in the game, you really can help with some of the knowledge and some of the education. Let me see, there was one other thing I wanted to mention on here. Oh, I also wanted, I like that Matt had said celebrate your successes. We had a reversal done by one of our police departments within weeks of giving it to them, and they were very glad. They got back with us, and we also had several of those police officers who came into our public health department and got a personal kit to carry when they're off duty because they had had that early success. So once again, I think that is really important to kind of focus on the success stories. All right. Now, in addition to the doses that we sent out to the first responders, Public Health has also gone out and trained staff at several of our community-based organizations to then train and distribute. Now, we have done this at our homeless shelter, and I have to say that has been mildly successful. We went and trained their staff. They went through the training. They seemed kind of on board with that, but they haven't requested that many doses from us to distribute. So I'm not really sure. We're kind of early in the phases of that, of seeing where the potential holdups are in that one. We also have a coordinated entry site where we have trained the staff, and that's run, the county works very closely with that coordinated entry site, but we have trained the staff at that coordinated entry site to be a distribution point. And we're really hoping that that's going to be successful in reaching one of our target populations that we've had a hard time getting to. Now, that coordinated entry site has only been open for about the last 4 months. So we're seeing increased flow through there, and we're expecting that to be our biggest public distribution site. We have also trained 2 residential treatment centers. Well, one's a residential/intensive outpatient treatment center, and the other is a residential treatment center. We've trained their staff, and they're distributing naloxone to any of their participants that come through with a history of opiate use disorders. We also have provided a public distribution site here at our health department, but we have only had to date 1 person come in and request a kit. Now, we didn't expect this to be our highest distribution point, but we're also looking at ways to market this to get more people in, and that we're having, I think, a little bit of difficulty getting that out to the extent that we would like to see from public health here. And the other component that we have that most people probably have in their jurisdictions as well is methadone clinics. So we have 2 local ones that we are working closely with, and it's interesting, they're very different in how they're distributing naloxone and or the number of patients that they're able to meet. So we have Aegis here that's sort of statewide, and they, of course, got significant funds for the medication-assisted treatment expansion project throughout the state, and we have a hub that's in Marysville within Yuba County. Now, Aegis has been a key participant in our coalition. They funded a significant part of our opioid coalition, and they also have within that grant the ability to provide naloxone to various components. Now, once again, I had mentioned that our coalition is a bi-county and or potentially a tri-county because our medical society is a tri-county, and the surrounding county, Sutter County, which is just next to us, has decided not to distribute naloxone to their law enforcement. So Aegis has sort of picked up slack in that. I'm not sure if it's actually taken place, but they plan to provide naloxone to the law enforcement on that side of the river. So within our coalition, there's some differences because the counties have slightly different distribution plans as far as the public health level. They also have offered any naloxone to, if we decided through public health not to continue the funding source for it, they plan to sort of pick up the slack on our side to give it to law enforcement over here. The Healthcare Council and the Opioid Coalition is in the early phases, but are committed to starting a syringe exchange program in our area. We don't have any in our county for sure, and any in the surrounding counties where our people can access. So that is the next step that the Opioid Coalition is going to focus on, and Aegis has agreed to provide naloxone to that as well, which is a huge benefit. Our other opiate treatment program does not and then Aegis also is providing naloxone to each of their participants who go into the hub there. However, our other methadone treatment program has not historically been providing naloxone, and we just recently, I believe the training happened last week, we just had a training scheduled to go in and train their staff on how to distribute, and we're either going to, there was, you know, each organization's a little different in their comfort level, and we weren't sure if we were going to give them naloxone to start distributing to their participants or have them come into public health. So that's sort of up in the air at this point, but another example of a very useful partner to have within the community, and we found great success in sitting down with them at the table. Now, the other component of this that I think is useful to mention that is a little, that I think, had some difficulty kind of getting everybody to the table was our local FQHCs. We have one that's definitely on board with providing treatment for opiate use disorder. They're co-prescribing naloxone. They've at one point, and I'd have to check to see if they're still doing this, they were actually stocking naloxone at one of their pharmacies that was located in their clinic. Our other FQHC, our other major FQHC in the area has not been as receptive to this at all. So I think that's one thing we're still working on to get them to the table, and I do think that our Healthcare Council, having that component joined up with our Opioid Coalition, has been very successful in doing that. And that is where we are right now, and I think that I'm done with my slides now. I think the next one we have is a recorded presentation, and I look forward to answering any questions.
Thank you. That was excellent. Yeah, and look forward to the conversation later where we can dig into some of those details. Next we have Andrew Woodruff, who is the Director of Plumas County Public Health Agency, which is a new designation for him, and in fact, he's joining us via video, right? And the reason is that I think today is the day that Andrew is being designated as the Director of Plumas County at a board meeting, so he wasn't able to join the call, but was nice enough to record his contribution yesterday. And from Plumas County, we have his partner in crime, James Wilson, who will be joining us for the discussion of this program that they've implemented there in Plumas. And you see a picture there of Andrew and his black cat. I guess the black cat has now crossed all of our paths today. Andrew's worked for the Plumas County Public Health Agency for 3.5 years and been acting director for 11 months. He loves practicing public health in rural California, welcomes visitors. I've had a chance to visit him up there. It's a really inspiring program, and they've made a lot of progress, especially as you'll hear in partnering with their syringe exchange program. Take it.
much to our funders and supporters of both our HIV and Opioid Coalition work. I'm always available to answer questions, and then my staff, both James Wilson and Barb Schott, are available as well. Thank you.
Thank you, Andrew, from yesterday, and congratulations on being named as the director. We're now going to move into available tools and resources. I'm driving, right? So this is a platform that's now available for all the coalitions to log on to on the California Opioid Safety Network webpage, and we are continuing to assemble resources for you in your work. This is actually a list of resources that are on the page organized around preventing overdoses currently. I'm not going to read through all of them, but most of them relate to items that have been discussed today. And then we're also going to be adding to that some of the more nuts and bolts things like protocols for administration of naloxone in schools, protocols for furnishing naloxone for inmates upon release. These are some of the protocols that coalitions themselves have built who have agreed to make available in Word form so that anyone can actually go in and take it and add your logo and make little modifications if you're looking to do that kind of work in your own jurisdiction. And we're also inviting anyone who has protocols of this nature that they can share to actually send them in as well. And we'll assemble a library of like products that people can find and select. So that's the tools that will be available. Oh, there we are. That's my 7-year-old, Rosie. That's Basil, reminding us that the work that we're doing today is not only for for those around now, but for the next generation and for the future. So now we'll open it up to the discussion.
Great, thank you so much, Matt. So we're now moving into our discussion portion. As always, in order to do this well, it's great to have people actually be on the phone so that we can have kind of some interaction and you can describe your questions in more detail. But that said, if you can't do that, we're happy to take them, and we know that some questions have come in through the Q&A panel as we've been talking, which is fabulous. So on your screen right now are the dial-in instructions. Please follow them. You'll use the telephone icon that should be at the bottom of your participants panel. That'll direct you to it. When you press this, a pop-up will come in and you choose I will call in from that pop-up, and then you'll get a 3-step dial-in information on the next pop-up on your screen. It'll have a call-in number, an access code, and an ID code. Please use this and follow these instructions with your codes because it links your name to your call-in, and then we can call on you directly to unmute you, which makes the process a lot simpler. I'm now going to pass it back to Matt to review questions that have come in and to begin us with our discussion portion while you're all calling in.
Thank you. I want to introduce a special guest we have with us today, Alessandra Ross. Alessandra is the Injection Drug Use Specialist for the California Department of Public Health Office of AIDS, where she leads work to expand access to sterile syringes in order to prevent HIV and hepatitis C and other infections, and really takes a whole person approach to the health and wellness of people who use drugs, including overdose prevention and response. And Alessandra, if you can call in along with the others.
Oh, she's in.
All right.
She just called in.
Great. Offer your perspective on the support that you've done for Plumas County. We've heard from Yuba County that they're interested in moving forward with a syringe exchange program. And I'd like to hear, briefly what the state of the state is with regards to needle exchange. Thanks.
Sure. Currently, there are 44 syringe exchange programs in California, and they are, if you go to our website, you can see a map of them. You can see how they tend to be clustered on the left coast for very obvious reasons. I think that at the local level, they had always been authorized by local government, and that led to an emphasis on syringe exchange programs where local governments are more progressive or less conservative, or however you want to frame that. And now CDPH also has the authority to authorize syringe exchange program, and we've found that that is not just supportive to places that have, where there might actually be opposition to such a move, which wasn't true in Plumas County, but it's also, it relieves the responsibility for those local government, those local lawmakers to make that decision, and it really provides that state level support that exists in other states. So one of the amazing things about these programs is that they're really working at the intersection of several different epidemics. It's not just overdose or HIV. It's also hepatitis C. It's staph infections, MRSA, bacterial infections, endocarditis. And these programs are really working at the ground level with people who are continuing to use drugs. And there aren't that many kinds of programs that do that. A lot of programs the services are only available to people who are abstinent. And harm reduction programs are available to people as they are right now, with a real emphasis on engaging people. And, you know, the metaphor that I always use is that if you're a smoker and every time I see you smoking, I say, you know, that's really bad for you. You're not going to avoid smoking, you're going to avoid me. So this brings people into engaging with services, knowing that they are accepted and not judged, and that gives them space to make behavior change that might be really valuable to them in this moment.
Thank you so much. And I think this is a great opportunity to just strengthen the relationship between the Opioid Safety Network and CDPH around what is emerging as, you know, a more important strategy for us around syringe exchange, given the evolving nature of this epidemic and the increasing fraction of people who are using through injection. So if you can stay on the line for any of the questions that come up. I'm going to start with some of the questions we've gotten so far. So one question was, how good is our fentanyl overdose death data in terms of, you know, how much of this is an artifact when we see these huge spikes in fentanyl, an artifact of surveillance? The answer, I think, is that we can't know for sure. However, in places like Ohio, you know, back east, the majority, like 67% of opioid overdose deaths in the state of Ohio last year, which has much higher overall overdose death rates, were due to fentanyl. And that's part of the, you know, many public health threats, you know, or trends will move from west to east. This is something that seems to be moving in the opposite direction. And we're seeing real data from back east of increased contribution of fentanyl. And so it's really, for a lot of people to see it, it's just a matter of time for California. So when we see our numbers jumping up, while it may be partly related to increased vigilance, it's also very likely related to an actual change in the trend. One question was, how do you get data about reversals? So I think that relates to the question of, or the suggestion that reversals be celebrated. You know, others may have other perspectives on this. I think this is, you know, in a small county, you know, coalitions are based on relationships, and some of that is informal communication networks where you're working with your law enforcement partners. You may have, you know, between 5 and 20 different police districts in your county, and you're working with each of them to try and help them carry naloxone and doing trainings and visiting. And those relationships are established, and email communications and phone communications are in place. And if it's just a matter of saying, you know, let us know if that happens, you know, we want to help celebrate it, just as an a priori understanding of the relationship moving forward. Or if it happens in any other partner, hopefully the relationship itself is such that they will let you know if the naloxone that you distributed and helped them use was actually used successfully. And aside from that, there's, you know, I'm not sure we have developed strong surveillance systems that are allowing us to monitor opioid overdose in systematic ways in real time, and that's something that's a real gap in our surveillance that is being worked on. I'll address one third question before we open it up. Treatment following rescue. There was one of the callers mentioned that 10% of people who have reversals actually have a fatal overdose death within a year. Are we doing enough to follow up? And I think the answer is no, and we're need to make sure that point, and probably should have been emphasized, one of the most important predictors of a fatal overdose is a history of a non-fatal overdose, and that in systems where we're just looking at reversing the overdose and then moving on, we may be missing opportunities to actually tie that person into treatment and make sure they have the resources and tools necessary to move on to recovery if that's where if they're able. And we've done something like that in Marin with our EMS data, where we're actually have piloted a process where we're using 911 calls when someone overdoses to follow back with that person 3 days later after they've been discharged from the emergency department or the hospital, to make sure that they're actually aware of the options for treatment and to make sure that they have naloxone, either themselves or bystanders, friends and family, at their home. And if they don't, we'll provide that for them in order to sort of act upon that knowledge that we know that they're, by definition, at much higher risk of a fatal overdose because they've already had one non-fatal event.
Great. Thank you, Matt, for digging into some of those questions. I know we've had a few more coming in, and we do want to point out that if you look in your chat box within WebEx, you'll see that we've posted some resources to share with you all, link to the naloxone grant program from CDPH and the CDPH and syringe exchange program that Alessandra was talking about earlier. So do check out those links and certainly continue to call in with some questions or send in some questions to us. We want to go and start having some conversations with you all and see if you have any particular questions for any of our presenters. Hear a little bit more about the work that you're doing around naloxone and harm reduction within your coalition. So first, I want to call on Lisa Hardy with SafeRx in Lake County. Lisa, if you could just share a little bit about the work that you all are doing related to naloxone and harm reduction, and certainly if you have any questions for our presenters and Matt here, please let us know. Lisa?
Yes, so mostly I've been working with our coordinator who's doing the academic detailing for providers in the county, and we were really learning a huge amount by talking to the different providers in the county. One of the, so we do, of course, talk about prescribing naloxone along with opioid prescriptions, and we just detailed a provider last week, and I ran into him in a social setting over the weekend. He said he'd already prescribed naloxone for 3 of his patients, so that was a real good feeling. But another provider told us that they are finding fentanyl in cannabis. And I don't know if that's in Lake County. He also practices in Mendocino over in Ukiah. But I was wondering, does anybody have any comments about that? That would certainly would seem like it opens up the whole, the whole audience for naloxone if it's going to be something that cannabis users might need also.
Alessandra, do you have a perspective on that?
I do. Some of what Harm Reduction Coalition has been finding in their use of fentanyl test strips, which is something that we fund, is fentanyl contamination in a lot of different kinds of drugs where they wouldn't normally be expected, in cocaine or methamphetamine. And I have not heard of cannabis, but it sounds like it might be part and parcel of the same findings. And the thought is that it is probably not put there intentionally, but is residue that was part of the drug packaging procedure. And what HRC really recommends is following universal precaution and really thinking about fentanyl as something that many, many people are currently using, especially in the East Coast, and are surviving, so that we really need to look at how do they do that and resist drawing conclusions that aren't supported by the scientific evidence, and urging people to be cautious in how they use their drugs. So there's a lot of drug education, I think, that's necessary for all of us, for drug users, but also for public health professionals, because we, especially on the West Coast, don't have experience in drugs being contaminated with this powerful drug, and how do we respond to that. But taking lessons that people on the East Coast have already learned about advising people to test their drugs before they use their drugs, for example, I think can be very helpful. But obviously, as public health professionals, we need to do some planning.
And is there any way that we can get, how would we go about getting fentanyl test strips to distribute in Lake County?
Oh, that's a good question. They can be distributed through your syringe exchange program. Anina Van Voren would have access to those through the syringe exchange supply clearinghouse. And then I can also just follow up with Matt on other resources for places that are not syringe exchange programs.
Okay, great. Thank you.
Mm-hmm.
Can I just call that out for yeah, the question was, how do we get fentanyl test strips at the local level? This is, to me, an example of how we might have an accelerated response in the Accelerator program, which is, CDPH just came out with this data that we saw a threefold increase in fentanyl-related deaths in the state of California, which is going to require that we can flex and adapt our strategies. And it could be that testing of fentanyl is something that we should be doing more frequently. I know CDPH is interested in helping us understand the dynamics better in terms of the evidence behind that, but we also know that that's completely new knowledge to many coalition leaders, even the existence of fentanyl test strips. So that's an example of something that if there's enough interest in that, we could do a call on that particular issue, in a couple months as we learn more about this, and that could be a strategy that we could try and advance more rapidly across the state through the network.
Great, thanks. And as Matt said, we'll be posting information in the Accelerator portal with all of these resources that have been described earlier and more that come along related to fentanyl test strips and kind of other protocols and documents related to naloxone harm reduction strategies. And the like. One other question that has come in is about the minimum age to carry naloxone, since some teens are starting to very early with opioids. Mm-hmm. Do we know the minimum age? Alessandra, is that something that you know about?
Yeah, there is not a minimum age.
Great. Okay, fantastic. So we're going to call on.
Can I just say, yeah? It's important, I think. Everything we can do to sort of make naloxone, people understand naloxone is not a medication, and it was typically the way we think about medications. I think a lot of the barriers are people sort of think of this as a prescription medication, or it's such a powerful antidote that there's sort of this implicit assumption that it's a powerful agent. It's actually a completely benign agent available without a prescription. Anyone can walk into a pharmacy anywhere in the state and actually ask for it without a prescription, no questions asked, and be furnished naloxone from a pharmacist. So our understanding of naloxone, I think, needs to be moved towards one of, it being like an over-the-counter medicine.
And that's really important, and that's right in terms of thinking about how we talk about naloxone, how we communicate with our partners, and kind of lowering any kind of fear or concern that we have within our communities about what this antidote really is. That's a really good point. I want to take a sec to call on another one of our coalitions. Sandy, Henley, and Butte Glen. I know we have a few folks on from Butte Glen. If you could talk a little bit about the work that you all are doing related to preventing overdoses, and certainly any questions you might have for our presenters. Andrew Miller from Butte Glen. Okay.
No. Let's bring up Jamie, Rich, and Patty Hoyt, who are both on from Contra Costa. We're going to unmute you together since you're from the same county. So you might have different questions.
Hi there.
So if you can share some of what you're doing in the county, and then if you have any questions.
I mostly have questions. We are one of these community-based organizations, so we're not part of public health and don't have all of those direct things. We're more on an education, public awareness, campaign-driven kind of thing. And I was fascinated with Dr. Willis's examples. I'm happy to hear that we're getting them about the protocols, because Jamie and I both have been working to get it in schools, and I think that'd be a great thing. You know, you see the thing about libraries. I don't think that's common here in Contra Costa County for our librarians in impacted areas to have it. So I'm excited about having that protocol shared with us. I think that's something we can really utilize and make a difference with.
Great. That's fantastic to hear.
Yep.
All right. Anything else from your coalition that you'd like to share?
Just that we've had fairly good luck with law enforcement. The word has gotten out. Most of our county, whether it's sheriffs or private police departments, are carrying naloxone. So we're kind of on to the next community member, which for us is the schools. And like Patty said, maybe we wouldn't have thought of the libraries, but the libraries next, because it seems like the law enforcement is pretty much on board.
Mm-hmm. For those of us trying to get naloxone into schools, the trend towards younger and younger youth, or fentanyl being associated with younger age and increasing overdose deaths, I think is another talking point that's emerging for us that hadn't been part of our conversation last year, but it's another reason why we really want to be working more closely with our schools.
Yeah, that was really valuable. Thanks for sharing that.
Great. And let's open the lines with Daniel Kim over with the San Joaquin County Opioid Safety Coalition. Daniel, if you could talk a little bit about what's happening over in San Joaquin.
Hi. Yeah, I guess so some of the challenges that we're still experiencing with regard to naloxone distribution. That's still, I guess, a question I know, for how do we overcome, I guess, some of the stigma with regard to law enforcement or some of our first responders in taking that. I do agree that, working with our first responders may be a first step before, reaching out to sort of public distribution, but we're just still experiencing, resistance for some of our law enforcement to take that on, and I'm just curious, if there's any strategies behind to kind of help overcome that.
And actually, since we just heard from Jamie and Patty, who said that they're kind of moving on to the kind of schools and community-based partners and had some successes working with law enforcement, would you all maybe share some kind of lessons learned or any advice that you might have for others who are looking to work with law enforcement around naloxone?
Sure. Well, go ahead, Jamie.
Well, we had one champion who was in the Sheriff's Department and was leader, I think, on the first aid for the whole county sheriffs, and he was a strong proponent of safety and naloxone distribution. So having that one really strong ally definitely helped us. And then from there, we also locally met with different agencies, the three of us, and talked to them about the importance of naloxone, and most of them from there readily agreed and went on to supply their officers.
Can I ask you a question? Did you talk about their own protection as part of that in terms of touching?
Absolutely. Theirs and their canines, to be honest. Yeah.
This is Nicole. One thing that was useful, I was just going to add in Yuba County is surrounding counties had already, their sheriff's departments had already decided to carry naloxone. So sometimes bringing up other local, like close local examples of people that are already doing it is useful. And we also, when we presented or approached all of these different law enforcement or first responders, some of them came to us requesting, but the ones that we approached, we often talked about it as a, you know, just you are a community member here, and this is something that is for you as well, and sort of the personal component, their protection, and I do think that went a long way.
And this is Patty. I'm going to say we probably tried to start this maybe 3 years ago with law enforcement, and we're kind of shut down because of the fact that our one of the members or one of the leaders in public health was not convinced that law enforcement needed it, that EMS had it, and that was probably sufficient. So until that leadership changed, we really weren't going to get very far because sheriff said, well, we got to wait until we get the blessing. So I think things change, you know, with leadership and with all this data that we now have that we didn't have so much of 3-4 years ago.
Great, no, that's fantastic. And one of the pieces that we'll be working on with around our Communicating for Impact series is we're putting together a series of talking points and tip sheets for working with these different partners and some of the messages that have shown to really resonate in implementing these strategies. So some of these kind of tips and lessons learned that have come up from other coalitions we'll be putting together in kind of messaging sheet that you can use going forward.
That's fabulous.
Great, so I think we'll be wrapping up here. We are close to the end of the hour. I really want to thank all of our presenters today for sharing their insights and for the rich discussion, and certainly to our main presenter, Dr. Willis, for his great overview. Just a reminder that we will be sharing the slides and the recording both on our public website, and then for those of you, most of you are in our Accelerator program, our new portal that we just launched this week. You can log into the portal and find all of those resources and recordings there. This is our website that you see here on the screen, CaliforniaOpioidSafetyNetwork.org. And we do have an upcoming core webinar on strategic communications, as I was referencing earlier, on tactics, tools, and timing, and how to set up a communications plan for your coalition. So please be sure to register for our June 12th webinar. And with that, this is our contact information. Thank you so much for participating today, and we will talk to you all soon. Thank you, everyone.
Thank you.
Thank you.